discuss the second case scenario in our series Clinical Case Scenarios. The second case scenario. This is a 56-year-old woman who was admitted for 2 episodes of vomiting of fresh blood associated with clots. She gives a history of intermittent epigastric pain for the last few years and was investigated and told to have a chronic liver disease. She is a known case of diabetes mellitus for 10 years and had a left below knee amputation done 4 years ago. On examination, she was slightly emaciated, she was mildly jaundiced and slightly pale. She had bilateral pedal edema. The BP was 110 over 60 millimeters of mercury and the pulse rate 110 minute and of good volume. The abdomen was markedly distended with positive fluid thrill and shifting dullness. No abdominal tenderness and the liver and spleen were not palpable. Okay, these are the questions for you, for the students. So please go through these questions and try to answer them before proceeding to look at the answers that follow. Okay, now let's analyze this case. It's a 56-year-old woman. I've underlined the important parts of the history in blue here. 56-year-old woman, 2 episodes of vomiting fresh blood with clots. She gives history of intermittent epigastric pain for last few years and was told to have chronic liver disease. Now, what are the positive symptoms in this history? So the positive symptoms will be 2 episodes of vomiting fresh blood with clots, important also with clots. Intermittent epigastric pain, chronic liver disease with diabetes and BKA. There's not much history in this patient which is forthcoming. As a result, we would like to know the details of the chronic liver disease, what was done and what treatment is being carried out. We want to know whether she had a past history of hematemesis and jaundice, and also whether she had any epigastric pain. And we're also interested to know whether she has done investigations such as ultrasound and OGDS. So these are the causes from the history that we have got. Okay, the problem with this patient is a 54-year-old female, chronic liver disease for 2 years, now massive hematemesis with clots. So the likely causes are esophageal varices with bleeding peptic ulcer disease, erosive gastritis, carcinoma of the stomach, or Mallory Weiss tear of the esophagus. Okay, bearing this in mind, the examination findings were she was emaciated, mildly jaundiced, slightly pale with edema and ascites. BP was on the low side. The heart rate is elevated to 110 per minute, but the volume was reported as good. And then there are signs: fluid thrill and shifting dullness and abdominal distension. These are all signs of ascites. So in summary from the history, from the examination, is a emaciated patient, tachycardia but no motensive, mild jaundice, pallor, edema, distended abdomen, and fluid thrill and shifting dullness. The negative signs in this patient for no tenderness is important. There's no abdominal tenderness, and the liver, spleen are not palpable, are not enlarged. And also, we were not told of any signs of chronic liver disease such as spider nevi, dupuytren's contracture, or caput medusae. which we need to look for in the patient. So from the examination, these are the findings which we already mentioned. So the causes from these will be cirrhosis of the liver with bleeding esophageal varices, can be a hepatoma, or CA, stomach with metastasis. So the clinical problem in this patient is, in this 54-year-old female patient, is she's emaciated with jaundice and features of liver cirrhosis. So the clinical problem will be liver cirrhosis with hematemesis. This is the clinical problem. Based on this clinical problem and the features that suggest that problem, we can come to the diagnosis and differential diagnosis. Okay, the diagnosis will be liver cirrhosis with hematemesis due to bleeding esophageal varices. This is our provisional diagnosis. And these three will be the differential diagnosis: carcinoma of the stomach, erosive gastritis, duodenal ulcer. Okay, these are the questions and answers that I have proposed earlier for you. So those of you who answered, this will be the question. Firstly, what is the most common chronic liver disease the patient could be having? In our setting or in most settings, most situations, the chronic liver disease, the most common is liver cirrhosis of various causes. Okay, can be alcohol liver cirrhosis or hepatitis cirrhosis. These are the two common ones. What are the common signs of chronic liver disease? Patient will be jaundice, usually mild jaundice. You will have features of hypoalbuminemia, edema, ascites, can have spider nevi, palmar erythema, Dupuytren's contracture, and a patient of feeling generally unwell. Question number 2. What is the most likely cause of the hematemesis in this patient? So, esophageal varices. Okay, liver cirrhosis with esophageal varices. How will you assess the severity of the bleeding in this patient? First, clinically, the amount of blood, presence of clots, the BP, pulse and pallor, per rectal bleeding and melena, and then using the clinical scores of Blashford and Rockall scores. Okay, and also the mental status of the patient, drowsy, restlessness, to suggest the patient is in coma, hypovolemia. Question number 4. Name the diagnostic procedures that can be determine the cause of bleeding. The diagnostic procedure will be upper endoscopy or OGDS. And the last question, what is the long-term management or treatment of this patient? Okay, first, to reduce the portal pressure, which can be done by medical or surgical procedures. And secondly, to treat the cirrhosis with diet, avoid alcohol, low protein, and also antidiuretics to control the edema, and also giving the patient albumin. To answer the final question, what is the long-term treatment for this patient? I have summarized the treatment of varices, esophageal varices in this patient. The most important is to reduce the portal pressure. This will, by reducing the portal pressure, it will reduce the bleeding from the varices. And this can be done by using medication such as beta blockers like propranolol at the rate of 40 milligrams PD, sandostatin, usually for in the early phases of bleeding, IV infusion of sandostatin or octreotide, which is a hormone, and vasopressin. Vasopressin also given through infusion during the acute phase of bleeding, and this will cause vasoconstriction of the blood supply to the lower end of the esophagus and thereby reducing the venous bleeding as well. And also there are surgical methods where you create a shunt between the portal and systemic vena cava. This is known as portal systemic or portocaval shunts. And the most widely used is the endovascular method known as the transjugular intrahepatic portosystemic shunt. I shall show you this in a short while. The next important method of treatment is endoscopic, which is for the bleeding, and this can be done as an injection sclerotherapy, whereby sclerosant is injected into the bleeding varices to clog it up and stop bleeding, or the injection of acrylate, which is a glue that causes blockage of the venous veins that are bleeding and thereby stop its bleeding. The second important method is ligation of varices or bending of varices, which I will show you in a short while. Apart from this, generally for long-term management, there is healthy lifestyle. Promoting a healthy lifestyle, like abstaining from alcohol, adequate diet, protein in the diet, and also regular exercise and medications such as diuretics, albumin, and also to reduce the pressure, as I said, is your long-term use of propranolol orally. This concludes my discussion on clinical case scenario on esophageal varices with hematemesis. Now I come to the second stage where I'll go through some salient points about esophageal varices. Esophageal varices are dilatations of the portosystemic anastomosis in the lower end of the esophagus. These dilated veins are swollen, thin-walled, and hence prone to rupture, with the potential cause of catastrophic hemorrhage, and which can be very sudden, severe, and fatal. The most common underlying cause for esophageal varices is portal hypertension, which is a result of liver disease such as liver cirrhosis, and one of the most common causes is alcoholic liver disease. Other causes of liver cirrhosis can also lead to the same problem. In any patient with hematemesis with known history of alcohol abuse or chronic liver disease should always be investigated with an urgent OGDS, esophagogastroduodenoscopy. Okay, this is a picture showing you the esophageal varices, which are enlarged veins at the lower end of the esophagus due to a cirrhotic liver that causes increased portal pressure. So increased portal pressure from cirrhosis of the liver causes enlargement of these veins, gastric and esophageal veins, and these veins are dilated, especially those at the lower end of the esophagus, which can lead to rupture and massive bleed. There are some special signs that you must look for in chronic liver disease like cirrhosis, spider angiomas or spironevus as they are called. This is a type of telangiectasis, swollen vessels found slightly beneath the skin surface, and these are usually found over the chest, anterior chest and upper abdominal walls. These often contain a central red spot and reddish extensions which radiate outwards like a spider's web. Second is caput medusae, is the appearance of distended and engorged superficial epigastric veins which are radiating from the umbilicus across the abdomen. Others include dupuytren's contracture, palmar erythema. Okay, these are all special signs of chronic liver disease. Next, we come to assessment of severity of bleeding in esophageal varices. There are two methods of scoring systems that are available. One is the Glasgow-Bashford scoring system, or the GBS, which assesses the severity of the bleeding and assess the likelihood that a person with upper GI bleed will need to have medical intervention such as blood transfusion or endoscopy. So this will assess the severity, and this is based on number of parameters as mentioned here: blood urea, hemoglobin, systolic blood pressure, the other such as heart rate, and the presentation. Okay, these are the things that you look for in these patients to assess its severity, to see whether they need further intervention. The second system of scoring is known as the Rockall risk score or Rockall scoring system. Okay, this identifies the patient at risk of adverse outcome following upper GI bleeding. Okay, so this will determine the prognosis of these patients come with upper GI bleeding. Okay, whether there's morbidity and mortality, that is, it will predict. The scoring system uses the clinic criteria of increasing age, comorbidity shock, as well as the endoscopic findings, diagnosis, and stigmata of acute bleeding. Okay, these are the parameters that takes into consideration, and also the comorbid situation of the patient. Okay, so this is the prognostic indicator, whereas the Glasgow Blatchford is a severity indicator. Another important thing to understand is the portal systemic circulation. There are two systems that meet in the liver: the portal system, from the carrying food nutrients from the bowel, small intestine, and the systemic circulation, that's the blood in the vena cava, inferior vena cava. At certain parts in the body, there is a anastomosis between these two circulations, and these include the lower end of the esophagus, around the umbilicus, and also around the lower rectum and anal canal. So these are the three primary sites where there's anastomosis and predisposed to bleeding, and there's increased portal pressure. So, okay, this is the portal system coming from the intestine, joins to form the portal vein, which enters into the liver and then forms the anastomosis around the sinusoids, which again unite, the veins will unite and carry the metabolized blood into the inferior vena cava. Okay, so this is a portocaval shunt taking place in the liver. As I said, cirrhosis of the liver increases the portal pressure. As a result, this circulation is blocked. As a result, what happens? The varices at the lower end of the esophagus will get dilated and start bleeding if the pressure increases too much. Other areas that can bleed is around the umbilicus, such as the caput medusae, and also the anal canal, anorectal region, as hemorrhoids. The grading of esophageal varices is easily done by upper gastrointestinal endoscopy, or OGDS. At the OGDS finding, you can grade the varices from 0 to 4. At 0, there is no varices. Stage 1 or grade 1 is when there are microvessels that stretch like varicose strings, okay, located in the lower end of the esophagus. Grade 2 will be when there are 1 or 2 fine caliber vessels, which are very small vessels less than 3 millimeters in diameter, located in the distal esophagus. Grade 3, when the vessels are of medium caliber varices, and this is between 3 to 6 millimeters in diameter, or more than varices up to 3 millimeters that may reach up to the middle third of the esophagus. And stage 4, thick caliber varices larger than 6 millimeters in diameter, in any part of the esophagus, not just isolated at the lower third. Okay, this picture shows you the various grades of esophageal varices as seen on endoscope. Here is grade 3 to grade 4. There's grade 4. The whole length of the esophagus can be involved. This is grade 2 to grade 3 when there's a localized segment of varices. Okay, and this is grade 2, grade 1 to grade 2. There's only single varices and the veins are smaller than 3 millimeters. So you have early and late stage esophageal varices. And these are very severe esophageal varices seen here. That on the right side you can see a large esophageal varice which is actively bleeding. Here you have got 3rd to 4th degree esophageal varices. And this is again another picture to show you severe esophageal varices, and this is known as the cherry spot, which is a sign of recent esophageal bleeding from this point. Okay, coming back to esophageal varices. Esophageal varices, the management should be swift and performed at the same time as resuscitation. Thus, cannot wait for resuscitation to be over. As you resuscitate the patient, you must treat the patient actively. Okay, using of blood products and prophylactic antibiotics. First is endoscopy, and the most important or most commonly done is bending. Endoscopic bending or ligation is one of the most important, but sometimes in a bleeding ulcer it can be technically very difficult as well. Injection sclerotherapy again is also an endoscopic procedure where sclerosant is injected into the bleeding esophageal varix, thereby trying to stop the pressure bleeding. And intravenous medications such as somatostatin analogs or vasopressors are also given in infusion to reduce the portal pressure and thereby the pressure at the varices to reduce its rate of bleeding. Then long-term management warrants repeated bending or injection sclerotherapy of the varices and long-term beta blocker treatment. During the active phase, when we are unable to do endoscopy because of the massive bleeding, a sense-taken Blackmore tube can be used in some cases. Okay, in some severe cases. It is inserted to the level of the varices and inflated to compress the bleeding. It is a compression treatment, which I will show you in a short while. Okay, this is the rubber band using the scope, and these rubber bands are used to ligate, bend the varices. So bleeding varices sucked into this ligator, and then at the neck of these varices, a tight rubber band is applied to constrict and bleed and stop the bleeding. This is known as rubber bending or ligation of the esophageal varices. Okay, this is how after the ligation the bleeding stops. Okay, here a lot of bleeding here, so you apply the rubber band. Okay, and this is the injection. Okay, where injector is used to inject sclerosing agent. The most commonly used is Thrombova into the varices, bleeding varices, and thereby trying to stop the bleeding. This is the Stank-Staken Blackmore tube, which is a tube with 3 balloons or 3 ports here, and there are balloons. This is a gastric balloon and this is a esophageal balloon. So this tube is inserted through the nostril or through the mouth down the esophagus, and the esophageal balloon is placed at the lower end of the esophagus. The gastric balloon is placed inside the stomach, and these balloons are inflated usually with saline, and by inflating, this balloon applies pressure on the varices and thereby prevent further bleeding, temporarily stop the bleeding. The gastric balloon also, apart from compressing the gastric veins which may be dilated, also the balloon prevents the tube from being slipped out of the stomach. Okay, this is an emergency use where the patient unable to do any endoscopy because of massive bleeding. So what we do is put a tube, Sengstaken black mode tube, inflate the balloons for 12 to 24 hours, and then take out, and then you do the endoscopic procedures after that. The surgical procedures involved is creating a shunt between the portal and systemic veins. Okay, this is the IVC and this is the portal vein. This can be done through endoscopically these days, and that is known as the transhepatic portosystemic shunt, or TIPS, TIPS, transjugular intrahepatic portosystemic shunt. Nowadays, this is done through endoscopical method through the endovascular system, and where the graft is placed between a branch of the portal vein and the IVC. So this shunt is known as the portohepatic shunt. Okay, nowadays we can be used expandable mesh, which when placed after some time it expands and creates a fistula between the portal and venous system. Okay, cable system. So this is the porto-cable shunt. By diverting the blood from the portal system, that is the liver, it reduces the pressure in the portal system, thereby reduces the rate of bleeding from the varices as well. Okay, this is an algorithm management of acute variceal bleeding. First of all, you have to resuscitate the patient. First, you suspect there's variceal bleeding, you resuscitate the patient, which I mentioned. Okay, IV access, cross-match blood, transfuse blood. Okay, then you give these octreotides or vasopressin, somatostatin. These things usually given for the first few days and see whether the bleeding controlled. If the patient is stable, then you go for urgent endoscopy. Okay, urgent endoscopy, you confirm varices, where the varices is, esophagus or gastric. Then you can continue with your injection sclerotherapy or ligation of the varices. Okay, so if it continues to bleed despite that, then you may want to go for TIPS, surgical intervention. Okay, if the sclerotherapy and all are controlled, persistent bleeding active stops, then you continue with long-term management. If the bleeding continues, then you may want to go for TIPS or surgical shunt procedure. Okay, so it's an urgent procedure. Esophageal varices, try the endoscopic methods. If cannot, temporarily you use a Sengstaken tube to control the bleeding, and then if the bleeding stops, then you inject the patient or ligate the varices. If it continues to bleed, then you have to go for surgery. If it stops bleeding, then you look for long-term beta blockers and cirrhosis management of the patient. If the endoscopic service is not available, then you use a balloon tamponade, put in a balloon, Sengstaken black mode tube, control the bleeding, and transfer the patient to the nearest endoscopic center. Okay, this is a simplified version of the management of acute variceal bleeding. So finally, the key or take-home points from these few slides on esophageal varices. Regardless of the underlying cause, adequate initial resuscitation should always be the priority. Most cases of hematemesis, or in fact I would say all cases of hematemesis, should be investigated with an OGDS, which must be done urgently. Various scoring systems are available to allow for the risk stratify of patients admitted with an upper GI bleeding, such as the clinical criteria, Rockall and Glasgow Blatchford score system. I hope this short discussion on the clinical case scenario on esophageal varices would have been great help to you in understanding the topic in a much better way. Thank you.